All right, everyone. I am so sorry about that delay. Just was muted. All right. Good morning, everyone. See, we do have a couple folks still coming in, but I think just in the interest of time, we will go ahead and get started. Sorry again about my voice. It is just not ideal, but we're just going to continue on. So I am really excited today to be facilitating this session. My name is Lauren Rabinowitz, and I am joined by our tech host, David. And this session is being recorded. Hopefully you saw that little message pop up. If you need transcription, that is available through Zoom. And if you have any questions, please go ahead and put them in the chat. We want to let you know before we begin that the views, policies, and opinions expressed in this presentation are those of the authors and do not necessarily reflect those of SAMHSA or HHS. So having said all that, I am really excited to pass it over to our colleagues at University of Maryland, to Kaya Swan and to Laura Latta. Thank you both so much, and thank you to all our participants for joining us today.
Good morning, and thank you, Lauren, for the warm introduction. We are really excited to be here this morning to present on the mapping and the Maryland Infant Early Childhood Mental Health Consultation Equity Mapping. My name is Kaya Swan, as Lauren mentioned, and I have my colleague Laura here. We come from the University of Maryland School of Social Work PIEC team, where we focus on parenting and infant and early childhood mental health throughout the state. We provide technical assistance, training, and implementation support to the local IECMH programs. We partner with them as well as a range of other state and local agencies to support the growth of system of care in targeting at-risk parents and young children. Again, my name is Kaya Swan, and I'm the co-director at the PIEC team with Laura. And I'll let Laura briefly introduce herself before we dig in.
Thanks so much, Kaya. So my name's Laura Lott. I'm the co-director with Kaya, and my background is in public health. And so I tend to take that perspective when we're looking at the data. I previously worked on an infant mortality reduction strategy in Baltimore City, and have been with the PIEC team for the past 3+ years. And so with that, I will hand it back to Kaya and jump on in.
Wonderful. Well, in the next 50 minutes, we will provide you with a brief overview of the Maryland's Equity Mapping Project. The mapping project we worked on was to identify where IECMH services were delivered across Maryland in the context of where the childcare programs were located and historically underserved children, including Black and Latinx children, through the time period of July 2017 through December 2020. This slide right here just gives you a brief listing of various equity research that has been done in the early childhood field. As you all are very much aware, the earliest years of children's lives present a tremendous amount of opportunity to set them on the trajectory for lifelong health, well-being, and success. The relationship and environments that children experience in their early years are critical to supporting their healthy physical, cognitive, and social and emotional development. Unfortunately, these opportunities are not equally accessible to all children in our society. Inequitable access to opportunity persists in our communities. And we wanted to be able to note that, but then also draw your attention to some of the research that's available in the field, well-known research that Black boys in early childhood settings are suspended or expelled at much higher rates than their white counterparts. And as you all know, IECMH is linked with reduction of suspension and expulsion rates. And as you know, that the work of consultation is intentionally a social justice and equity approach. And this slide just highlights some of the research in the field. All right, so Maryland's model, we noted a little bit earlier, but Maryland, we are funded all by the Division of Early Childhood, Maryland State Department of Education, and they've funded IECMH services statewide since 2009. Our agency is also funded. These are the programs that are represented across the state of Maryland, and they are within nonprofits, city governments, county governments, nonprofit organizations across the state. And we are funding, Maryland State Department of Education funds all 10 programs that are provided across all 24 jurisdictions, which we'll see in the next slide. So in this slide, we just wanted to basically highlight the fact that in some jurisdictions, some funded programs actually serve multiple counties within their regions, and others may serve as just one or two counties. And I think one of the things to note here is that there are over 4,500, over 6,000 childcare programs in the state of Maryland. And these jurisdictions and the IECMH programs cover all 24. And there's some urban, suburban, and rural communities that are uniquely situated within some of the regions. Okay, so we just kind of noted that we have tons of childcare programs in our state of Maryland. However, what we want to note here is that only about 4% of children are being serviced, childcare programs are being serviced across the state. So what we want to note is that there is way more childcare programs than our IECMH can serve. We're only able to serve a small portion of the eligible childcare programs in the state of Maryland. And so that made us start to really think about, are we equitably serving these, are we equitably providing IECMH services across the different regions and or within counties? And so there's some of the reflective questions that we were asking right there that we noted is really like what programs are more likely to receive services? What reasons are childcare programs being likely served over others? So we began asking these questions within our programs. And so the goal, as we stated a little bit earlier, was really just to identify where services were being delivered, and in what context were the childcare programs and families in need located. And so we did a equity mapping series where we looked at different programmatic maps as well as the state equity map. I'll turn it over to you, Laura.
Okay, thanks, Kaya. So as Kaya stated, so we're going to be reviewing a series of maps, looking at a number of different variables, and all for Maryland. But as we review, I think it's really important that you think about the region that you're serving. And so for each variable, think about, do you know what your map would look like? Whether that's for a specific, locality or a whole state. And then also be considering like, what do we want to do with this information? What decisions can be made? What decisions should we be making with this data? And then what's missing? What other data would be helpful? And so next slide. So for this first map is really looking at which counties have the higher densities of children under 5. So you can see how children of 5 are distributed throughout the state. And one thing to note is that over 2/3 of the children live in just 5 counties. So you can see Montgomery County with 18%, Prince George's County next, and then Baltimore County, Baltimore City, and Anne Arundel County. So right there in that middle, I'm pointing at my screen, but I know you can't see that. And so right in this area. Then next slide. So next we're diving into the racial makeup of the counties in Maryland. So this slide and the next two are going to be looking at the racial makeup. If you're looking, and so this is the percentage of children under 5 that are Black by county or jurisdiction. And you can see, like, of those 5 where the majority of children are, so Montgomery, Prince George's, Anne Arundel, Baltimore City, and Baltimore County, you can see that Baltimore City and Prince George's County were majority Black for this age group. And then in the next map, you're going to see, this is for the percentage of children under 5 that are Hispanic or Latino. And for this one, you can see that Montgomery and Prince George's have the highest percentage of Hispanic and Latino children under 5 in the state. But you can also see it's helpful regardless for all of the counties to know what their populations look like. And these are the statewide maps, but we also had, as Kaya said, a series for each of the programs so they could see what does this look like at the local level. And so more on the zip code area, by zip code. And then you can see what the percentage of children under 5 that are white by county or jurisdiction. And just to note, of those 5 counties that have the highest highest percentage of children, or make up 2/3 of the children in the state, only Anne Arundel County had a majority white population of children under 5. And then if you look at Maryland, like across Maryland, the percent of families living below the poverty line overall is 6%. And so you can see through this map what it looks like by county. And so looking at the 24 counties or jurisdictions, 8 counties had a percentage of families in poverty of 7% or higher. And you can see that Baltimore City and Somerset County marked the top end of this group with 15%. And then, but just when you were thinking about Baltimore City and Somerset with the highest percentage of families living below the poverty level, it is important to note that Baltimore City had significantly more children under the age of 5, so specifically 31 times more. So just, as you're seeing this, what sort of questions come into your mind? What more information do you want to know? And then just noting, this is the distribution of licensed childcare programs in Maryland. Again, lines up with where the children are throughout Maryland. So you can see the highest densities in those 5 counties. And then lastly, we wanted to look at, okay, what is the distribution of referrals in Maryland? Okay. And so with this map, you can see how this is the accepted referrals across the state. And you can see, Baltimore County and Montgomery are the highest, but you can, it's we want to sort of see who's receiving services, where are we low in terms of referrals and accepted services. And then one thing, like this is the same slide that you saw earlier that Kaya shared. And one thing that we think about is, with the current resources allocated for consultation in Maryland, we're only reaching about 4% of the childcare programs. And a key question is sort of which ones. So one of the things that we've been, thinking a lot about is just, when we're looking at consultation services from a public health perspective and thinking about how to reduce disparities, we need to think about the fact that most or all teachers are stressed. I think this is something that we've been hearing throughout all of the presentations is just teachers are stressed. All classrooms can benefit from consultation, and there's limited resources. And so then that leads us to start asking questions, who gets to receive the services? Is it the programs that are, easy to work with? Is it the ones that seek out consultation? Is it the ones with staff and families who speak the language of current IECMHC staff? Are they the programs or people who haven't been historically exploited or harmed in some ways by services and therefore are more likely to accept them? And if we answer yes to many of these questions, then we may end up actually widening the gap and increasing the disproportionate rate at which Black boys and other historically disadvantaged populations are suspended and expelled. That's something that we really think deeply about in Maryland, is just, we want to be careful that while everybody needs and can benefit from these services, they aren't going simply to programs that already know how to access these services really well and are calling all the time and asking for help and easy to work with. And so these are just things that we want to be mindful of sort of at the state level. And then I want to share the next one. So the next two slides are really looking at when we created the initial series of maps for the programs, which we didn't share in this series. I'll in a couple more slides, I'll show you more at the zip code level. But when we created the initial series of maps for each of the 10 programs for their designated regions, many of them were able to come up with strong hypotheses regarding why they were not reaching certain areas. For some, it was language barrier. Some mentioned, oops, I'm looking at the wrong slide, I'm sorry. Okay, so this is just looking at some of the questions that we shared with the programs about the distribution of where services were, where families and children are located, where childcare programs are located, just to get them to start thinking critically about what the maps for their locality looked like and meant. And then this is these are the questions that we asked folks to dig a little deeper in thinking about the root causes. At a state level, when we looked at the maps, we couldn't figure out, we didn't have a lot of answers as to why there were a high number of accepted referrals in certain areas and not in others. But the programs, when they got to dig in, they were able to come up with some really interesting hypotheses and strong hypotheses regarding why they were not reaching certain areas. For some, it was a language barrier. Some mentioned partner agencies where there had been turnover and they no longer had a relationship with staff, so that referral source had dried out, and they realized, oh wait, we need to rekindle that and reach out to them. Some noticed that the areas that they weren't reaching were simply the furthest from their home office, so that maybe they weren't reaching out to them as much or didn't have that sort of regular check-in. So it just got them thinking, okay, what do we do with that? And we don't have the answers to all of these questions. These are really things that we get curious about. One of the things that Kaya and I have been talking about is just I'm curious how others in the country work to think about equitable distribution of the limited resources that other localities have. Another interesting paths that we've explored is how to use this type of data to inform how funds are distributed. So, for example, in Maryland, this data was used in the RFA for this fiscal year to justify that programs could use this data to justify the percentage of total funds that they were requesting. So when you typically think of a funding formula, a lot of the times it's, or the way that I've seen it done is, you could do it based on the number of childcare programs and what's the total amount of funding that would be needed based on a variety of factors, including poverty level, racial demographics, and the like. But with limited funds, we really wanted to look at, or they were able to use it at the state to look at how to divide up the funding, if that makes sense. Okay, no, this is a little blurry, but we have along with this, the statewide series, we have an interactive dashboard, which we can provide the link in the chat in a little bit. And this is really meant for local programs to be able to dig into the data and see, okay, what's going on. The purple stars are where the different programs are located. The different consultation programs are located throughout Maryland. The light purple shaded zip codes are areas where there is more than 6% of the families are living below the poverty level. And then the size of the black dots are the number of accepted referrals. Then when we dive into like if you actually dig in and click on one of the zip codes, this is the information that you'll see. So if we were to hover over this, you would see a little thing would show up that says that this is actually there's less than 6% of the families are living below the poverty level in this area. So this map, try to follow me with this one, or I'm going to try to explain this. Okay. So this map and then the next two, there are, this is all for the same program, data for the same program. The number of total referrals are that bottom left. You can see there's 12 accepted referrals from the period of 7/3/2017 to 12/31/2020. You can see the demographics, so majority white, 39% Hispanic Latino, and then there's a gap there. So we don't have the demographics on that population. And then you can see the number of childcare centers. So there's 8 childcare centers, only 8 childcare centers, yet there's 12 accepted referrals for this time period. So some are probably programs that have a great relationship with the program in that area and reach out to them frequently. Then the next, so for this one, for this zip code, 18% were living below the poverty level. And you can see there's 14 accepted referrals, more than double the number of childcare centers, so 19 versus 8. There were also 40 family childcare providers, whereas the previous zip code had none. And then you can see the demographics here as well. And so you start to wonder what's going on there versus the previous one. Then if we go to the next one, so this 24% were living below the poverty level. You can see there's 18 accepted referrals, 90 or close to 90% Black. And then you can see there's 5 childcare centers, so a few less than that first one, but then a lot more family childcare providers. And then the next one, so I have now this one. Okay, so the previous ones all had around the same number of accepted referrals. This one, there are none. Poverty rate in this zip code is the highest in that jurisdiction at 31%. And you can see it's not that they don't have childcare centers. It's not that they don't have family childcare providers. So there's 12 childcare centers. There's 17 family childcare providers. But they have not been able to have any accepted referrals. So this is just like a note of, this is really, really helpful information for a program to have access to and to be able to start to get curious about, okay, what's going on there? And looking into, okay, what do we do about this? If we realize we haven't reached them, what can we do? And then this is just another way of looking at the same data. And again, like that top one is less than 6% of families living below the poverty level. The next one, I believe, is, oh gosh, I'm going to butcher it if I tell you. Should have memorized these or written them down. This is what happens. The next one is 18%, and then 24%, and then 31%. And you can just see, you know, the differences in terms of referrals and then the number of childcare centers. And like, if you were to see this about your program, what are some of the questions that you may start asking? What are the next things that you would want to dig into? And that's a real question. So you can write write in the chat.
And I'm sorry, I should have mentioned, if anyone wants to come off mute, you can raise your hand and we can unmute you.
And I'm trying to catch up on the chat. I mean, and I did also want to mention that the way the data, I've shown you a couple different ways the data is presented. Some of the programs also had specific ways that they wanted to look at the data. And so I really think it's important. We all have different learning styles. Some people really, the maps are really helpful and they really like that visual way of sort of diving into it. Other folks really wanted, just give me the Excel spreadsheet and can we talk through that? And so I think it's just an important thing to note that like not one size fits all for using the data to inform service, service delivery. And then, okay, and then I'm seeing creative ways. Go ahead.
There was one that was around, do we have any data on how often referrals were made but not accepted? And why would referrals not be accepted? Lack of consultant capacity. So just wanted to address that. We do have data on how often referrals are coming in from specific programs. So for this purpose, and correct me if I'm wrong, Laura, we were wanting to just kind of note where services were provided for those that were accepted, not necessarily tracking how often we were serving a particular center in this data set.
Right. And there are, like, depending on the program, some programs have wait lists and we have that data. Other programs track it differently. So we have data issues that we need to kind of sort through when we're looking at this. I think somebody made a really good point of, did you include the race of like who's referring in our data? And we did not have that. And you can see how your like brain starts spinning, like, okay, what are the other things? Like, let's see.
The other thing that Carly mentioned was like, why would referrals not be accepted? So there's various reasons why programs may choose to not accept referrals. It could be something on information that they received in terms of it not being appropriate. It could be that they were waitlisted due to capacity issues, but that wouldn't be a reason to not accept it, but it's likely that would be a reason for it to be on a wait list.
Mm-hmm.
Hopefully that answers your question. Just going through. And then another one was, can you elaborate on referrals? Not sure. Referrals actually go through, so each program has an intake and referral process. And so at the time of referral, they may accept information around like what's happening in the child care center, whether it's a child specific, program specific referral and or classroom based referral. They collect some assessment information, demographic information at that point in time. And then they move it through their tiered system of support, tiered IECMH system of support. and then they would assign a consultant once they determine kind of from triage where that case should fall under tier. Not sure if that answered your question, but wanted to provide a little bit more information. Oh, what types of research? Okay. Program specific, individualized cases, and or classroom based. So we have all three models here in Maryland.
But I would say the majority are child specific,
without a doubt,
at least across the state. It may vary by program. And then I'm seeing some of Amanda's questions about any systems in Maryland designed to support the workforce in order to increase the number and availability of consultation services. You know, we work closely. Another sort of arm of our work is the pyramid model in the state. And working to expand sort of pyramid model coaches and for classrooms. We also work closely with the childcare resource centers, and they are all trained in practice-based coaching in the FAN, and we are work closely with them on referrals and different things like that as well. And then, are you able to enlist the help of early childhood school psychologists in the many districts? I feel like there's a huge, we've been, consultants have been asked to push into the schools because of the lack of, yes, please come off mute. It's conversation's always better. Or are you not able to? Oh, okay.
Sorry,
okay.
David, can we please unmute? Sorry, I'm having trouble doing it.
Oh, there we go.
All right, perfect.
Thank you.
Yep. So I'm a school psychologist in Montgomery County, and I work with preschool special education. But one of the, I guess, parts of my assignment is the itinerant population. So I do go into private preschool classrooms and kind of observe kids, but also sometimes I'm able to give the teachers kind of some insight on how to kind of manage those behavior concerns or what they can do if a kid is having a lot of difficulty with like separation anxiety and things. But I think from my understanding of this mental health consultation model, it kind of leaves out the piece of like school psychologists who don't work in like within our county. Infants and toddlers is who does kind of this kind of process of mental health consultation. And Montgomery County is a huge county, but there's only one licensed psychologist who supports all of these kids in this county. And I know last year when I spoke to her, they had a position open, but they weren't able to get, somebody in that position. But has there ever been any kind of work to kind of leverage the school districts, like individual school districts, and kind of work with the school psychologists or the school social workers that are there to kind of help with some of the supporting of these referrals that come in?
So I will say, or Kaya, did you want to? I was just thinking the Part C pilot.
Yeah, the Part C pilot is one of them. I think that would be more of a statewide kind of effort to better align it. There has been some opportunities in smaller counties that have developed strong relationships with their Part C and Part B providers within the jurisdiction. I can say that IECMH is funded for the private childcare providers in the county. Like that's who they're funded to support. And we don't, as you know, in Montgomery County, there's not a lot of capacity to go beyond just the privately funded childcare providers. And so that is a limitation by far of our state's model. But I would suggest you make local connections with your IECMH program, because there are smaller relationships being fostered in local jurisdictions. I know when I was in Howard County, we were working very closely with our Part C and Part B office, as well as the Judy Centers and Head Start Centers, to develop, a unique support system for that county.
Right, because I think it's important to kind of use some of the systems that are already in place and kind of increase that conversation between them, because we're mental health providers as well. And, you know, there's a shortage in the field of just all mental health providers right now. And so kind of using existing systems and kind of creating those bridges between them is something that I think could potentially help with this.
Yeah.
We completely agree. And I do think there's professional development opportunities, even just getting out all the providers in the same room to hear similar things at the same time would help to expand capacity, knowledge, and expertise. Sorry.
Right.
No, and I was just thinking that we did a Part C pilot with infants and toddlers with 3 different consultation programs in 4 different counties, but not with Montgomery County. And what that was looking at is really like, how do we had one of the infant and early mental health consultants attend the teaming meetings for the Part C providers. And part of it was really building the infants and toddlers staff, their knowledge and around early childhood mental health. And it ended up not being a huge amount of time. We initially thought that there would be a lot more, that the consultants would have to go on a lot more cases and attend with the infants and toddlers providers, but it ended up being that like the biggest biggest help was really them attending those meetings and helping to talk through the different cases and how do you if the child is screaming and yelling, how do you even get to work on speech or anything else, and so that sort of systems way of thinking is incredibly important and challenging with everybody's sort of limited capacity. And then these are a few of the different reports that we have, and we can certainly send them out. The equity report and dashboard are on our website. But I feel like I'm going to stop sharing my screen. I'm going to attempt.
I'm going through the chat to see if we've missed any questions. Yes, completely agree, Camilla, if I'm saying that right. Hopefully I'm saying that. I think also continuing the conversations both locally and from a statewide perspective can help. I mean, we've noticed that even just in across the state, there's limited knowledge about the about IECMH. So really continuing to share that we have these services, I think is helpful for people to join into the conversation and to build a system that is responsive to the needs that we have here in Maryland and beyond.
No, I'm curious, does anybody throughout the country thinking about sort of this equitable distribution, and what other ways do you all have of looking at that or influencing where services are provided? And I also saw something around Judy centers. We are working closely with Judy centers as well. Any other questions or comments? And I think we did have a question around the Tableau. This was the free version of Tableau. We're considering upgrading because there's a lot left to be desired. So we'll see. Okay, and what in terms of what are the same trends in DC? Or is everybody muted and can't get off mute as far as teacher needs and demographics?
We can unmute everyone if we want to have a little more
I just
casual
always find that's
conversation.
easier just to be able
Yeah.
to jump in. I think most of our
David, are you able to just unmute everyone?
just if folks want to
one
come
at
off
a time.
demon graphics.
Our participants should be able to unmute themselves now.
Lovely, thank you.
So go ahead. So everyone can now
wanted
just
to-
unmute themselves if you want to come off chat.
I wanted to just mention that in Georgia, we have begun mapping and recognize that it's very difficult. I mean, it's a great tool. We were able to find a lot of great information about what is really needed, where the gaps are in services, especially providers. And what we recognize is that we have such a great need, particularly in the rural area of Georgia, but the workforce is not there. So one of the things that we really are focusing on is how do we really provide those educational supports for the workforce in those particular areas. And we're doing that through our Georgia Association of Infant Mental Health, being able to offer those trainings, and so that everyone is kind of following the same competencies and really kind of understanding. But it is a real challenge, particularly we have 159 counties in Georgia. So
wow.
so it's really big. Where I'm in the metro Atlanta area, where we have, a lot of resources and a lot of providers who are interested in taking advantage of those services. But it is a workforce issue, really, in terms of kind of educating people around what is infant early childhood mental health, what does it look like, why is it important, some of just the basic things to be able to get people on board. So so I do think mapping is really, really valuable.
No, and I feel like you bring up another important point is like we have to be careful that we don't use this to then say that those areas that aren't densely populated, that we aren't providing services there. I think there is you could see that going in that direction, and I think that that's not something that we would want. And so we have to be really careful about sort of who are we leaving out in those rural areas, and making sure that we figure out how to include everyone. Other things top of mind in the last couple minutes?
I will just say that one of the things that we found helpful was to have conversation with our local programs, because they know their counties better than we do from a state level. They know, in particular zip codes who may be, that it could be potentially an industrial area, where on the map it just looks like they're not being serviced. But when you understand what is actually happening in those communities, it's helpful to have that conversation. Or you could have provider programs who say like, oh, there's 3 major childcare programs that were shut down or are no longer in that area, because it helps to like really give the picture of what's happening in those zip codes and or that county that only a local will be able to share.
I'm just curious. Are you all noticing kind of like a follow-up question to the point you were just making, Kai, like, there's so much pyramid work happening in Maryland. Is that also a factor of where referrals are in places that might be doing more pyramid work?
I mean, I think we have a lot of pyramid model trainings, but then in terms of actual implementation, we are just building out implementation sites now.
Okay.
And I don't know if that many come from those. I think one thing that we have found in working with local programs is that the childcare resource centers could be a great and very strong referral source, and they tend to have really great relationships and strong relationships with the family childcare providers. But in a lot of programs, they used to be, most of them are co-located. But even when they are co-located, the communication between them, they don't know what the other one does. So it's hard to articulate why they should be sending somebody over to consultation. For one program, they shared with us that they had like a series of sort of meetings and retreats, and that tended to increase sort of just the day-to-day conversations, which then led to increased referrals, because then they could call on one another and ask, okay, is this a case where I could send it to you? But
yeah, I'm always curious, because I have heard, just anecdotally, and this is obviously there's lots of different levels of implementation of everything, but certainly pyramid work, that sometimes there's actually decreased referral, not because that's how we want it to be, but just sort of, it's like, no, we're good, we got this. So, as you continue to expand, just I'd be super curious.
No, that'll be interesting to kind of look at. Yeah. Well, thank you all so much for having us. And anything else? Any other questions?
1 minute left.
Okay.
I think you've actually, we were having a conversation yesterday. We're like, which time do we use? Is the one on our phone, the one on our computer? They're always like a minute off. But I think we are, yes, at time. Thank you very, very, very much. I think this was an extremely helpful presentation. I personally love the maps. That is a way that I learn, and I do think funders really like to see it. So I think that is really just very useful. So thank you for sharing that, and thank you for sharing the link so everyone could take a closer look at that when there is some more time. Thank you to our great participants. Thank you for being such great, asking questions and coming off mute. Fantastic. And I hope everyone continues to have a great experience with the conference. We have a fantastic plenary coming up soon, and I believe there's a storytelling session right before the plenary. So we will see everyone soon. Thank you so much.
Oh, thank you.